Kawasaki disease is a disease of unknown cause that results in a fever and mainly affects children under 5 years of age. It is a form of vasculitis, where blood vessels become inflamed throughout the body. The fever typically lasts for more than 5 days and is not affected by usual medications. Other common symptoms include large lymph nodes in the neck, a rash in the genital area, and red eyes, lips, palms, or soles of the feet. Within 3 weeks of the onset, the skin from the hands and feet may peel, after which recovery typically occurs. In some children, coronary artery aneurysms form in the heart. While the cause is unknown, it may be due to an infection triggering an autoimmune response in those who are genetically predisposed. It does not spread between people. Diagnosis is usually based on a person's signs and symptoms. Other tests such as an ultrasound of the heart and blood tests may support the diagnosis. Other conditions that may present similarly include scarlet fever and juvenile rheumatoid arthritis. Typically, initial treatment consists of high doses of aspirin and immunoglobulin. Usually, with treatment, fever resolves within 24 hours and full recovery occurs. If the coronary arteries are involved, ongoing treatment or surgery may occasionally be required. Without treatment, coronary artery aneurysms occur in up to 25% and about 1% die. With treatment, the risk of death is reduced to 0.17%. Kawasaki disease is rare. It affects between 8 and 67 per 100,000 people under the age of 5 except in Japan, where it affects 124 per 100,000. Boys are more commonly affected than girls. The disorder was first described in 1967 by Tomosaku Kawasaki in Japan. Since April 2020, a slight increase in childhood illnesses similar to the Kawasaki syndrome has been observed in the USA and some European countries. The World Health Organization is examining a possible link with infections by SARS-CoV-2, the virus responsible for COVID-19. The Royal College of Pediatrics and Child Health has named the condition Pediatric Multisystem Inflammatory Syndrome associated with COVID-19 and issued specific clinical guidance. Signs and symptoms. Kawasaki disease often begins with a high and persistent fever that is not very responsive to normal treatment with paracetamol or ibuprofen. It is the most prominent symptom in Kawasaki disease, is a characteristic sign of the acute phase of the disease, is normally high, is remittent, and is followed by extreme irritability. Recently, it is reported to be present in patients with atypical or incomplete Kawasaki disease. Nevertheless, it is not present in 100% of cases. The first day of fever is considered the first day of illness, and the duration of fever is typically 1 to 2 weeks. In the absence of treatment, it may extend for 3 to 4 weeks. Prolonged fever is associated with higher incidence of cardiac involvement. It responds partially to antipyretic drugs and does not cease with the introduction of antibiotics. However, when appropriate therapy is started, intravenous immunoglobulin and aspirin, the fever subsides after 2 days. Bilateral conjunctival inflammation was reported to be the most common symptom after fever. It typically involves the bulbar conjunctiva, is not accompanied by suppuration, and is not painful. It usually begins shortly after the onset of fever during the acute stage of the disease. Anterior uveitis may be present on slit lamp examination. Iritis can occur, too. Choretic precipitates are another eye manifestation. Kawasaki disease presents with a set of mouth symptoms. The most characteristic changes are the red tongue, swollen lips with vertical cracking, and bleeding. The mucosa of the mouth and throat may be bright red, and the tongue may have a typical strawberry tongue appearance. These mouth symptoms are caused by the typical necrotizing microvasculitis with fibrinoid necrosis. Cervical lymphadenopathy is seen in 50% to 75% of children, whereas the other features are estimated to occur in 90%, but sometimes it can be the dominant presenting symptom. According to the definition of the diagnostic criteria, at least one impaired lymph node greater than or equal to 15 mm in diameter should be involved. Affected lymph nodes are painless or minimally painful, non-fluctuant, and non-suppurative. Erythema of the neighboring skin may occur. Children with fever and neck adenitis who do not respond to antibiotics should have Kawasaki disease considered as part of the differential diagnoses. In the acute phase of the disease, Changes in the peripheral extremities can include erythema of the palms and soles, which is often striking with sharp demarcation and often accompanied by painful, brawny edema of the dorsi of the hands or feet, so affected children frequently refuse to hold objects in their hands or to bear weight on their feet. Later, during the convalescent or the subacute phase, desquamation of the fingers and toes usually begins in the perungual region within 2 to 3 weeks after the onset of fever and may extend to include the palms and soles. Around 11% of children affected by the disease may continue skin peeling for many years. 1 to 2 months after the onset of fever, deep transverse grooves across the nails may develop, and occasionally nails are shed. The most common skin manifestation is a diffuse macular papular erythematous rash, which is quite nonspecific. The rash varies over time and is characteristically located on the trunk. It may further spread to involve the face, extremities, and perineum. Many other forms of cutaneous lesions have been reported. They may include scarlatiniform, papular, urticariform, multiform-like erythema, and purpuric lesions. Even micropustules were reported. It can be polymorphic, not itchy, and normally observed up to the 5th day of fever. However, it is never bullous or vesicular. In the acute stage of Kawasaki disease, systemic inflammatory changes are evident in many organs. Joint pain and swelling, frequently symmetrical, and arthritis can also occur. Myocarditis, diarrhea, pericarditis, valvulitis, aseptic meningitis, pneumonitis, lymphadenitis, and hepatitis may be present and are manifested by the presence of inflammatory cells in the affected tissues. If left untreated, some symptoms will eventually relent, but coronary artery aneurysms will not improve, resulting in a significant risk of death or disability due to myocardial infarction. If treated quickly, this risk can be mostly avoided and the course of illness cut short. Other reported nonspecific symptoms include cough, rhinorrhea, sputum, vomiting, headache, and seizure. The course of the disease can be divided into 3 clinical phases. The acute febrile phase, which usually lasts for 1 to 2 weeks, is characterized by fever, conjunctival injection, erythema of the oral mucosa, erythema and swelling of the hands and feet, rash, cervical adenopathy, aseptic meningitis, diarrhea, and hepatic dysfunction. Myocarditis is common during this time, and a pericardial effusion may be present. Coronary arteritis may be present, but aneurysms are generally not yet visible by echocardiography. The subacute phase begins when fever, rash, and lymphadenopathy resolve at about 1 to 2 weeks after the onset of fever, but irritability, anorexia, and conjunctival injection persist. Desquamation of the fingers and toes and thrombocytosis are seen during this stage, which generally lasts until about 4 weeks after the onset of fever. Coronary artery aneurysms usually develop during this time, and the risk for sudden death is highest. The convalescent stage begins when all clinical signs of illness have disappeared, and continues until the sedimentation rate returns to normal, usually at 6 to 8 weeks after the onset of illness. Adult onset of Kawasaki disease is rare. The presentation differs between adults and children. In particular, it seems that adults more often have cervical lymphadenopathy, hepatitis, and arthralgia. Some children, especially young infants, have atypical presentations without the classic set of symptoms. Such presentations are associated with a higher risk of cardiac artery aneurysms. Cardiac heart complications are the most important aspect of Kawasaki disease, which is the leading cause of heart disease acquired in childhood in the United States and Japan. In developed nations, it appears to have replaced acute rheumatic fever as the most common cause of acquired heart disease in children. Even when treated with high-dose IV regimens within the first 10 days of illness, 5% of children with Kawasaki disease develop at the least transient coronary artery dilation and 1% develop giant aneurysms. Death can occur either due to myocardial infarction secondary to blood clot formation in a coronary artery aneurysm or to rupture of a large coronary artery aneurysm. Death is most common 2 to 12 weeks after the onset of illness. Narrowing of the coronary artery, which occurs as a result of the healing process of the vessel wall, often leads to significant obstruction of the blood vessel and the heart not receiving enough blood and oxygen. This can eventually lead to heart muscle tissue death, i.e., myocardial infarction. Valvular insufficiencies, particularly of mitral or tricuspid valves, are often observed in the acute phase of Kawasaki disease due to inflammation of the heart valve or inflammation of the heart muscle-induced myocardial dysfunction, regardless of coronary involvement. These lesions mostly disappear with the resolution of acute illness, but a very small group of the lesions persist and progress. There is also late onset aortic or mitral insufficiency caused by thickening or deformation of fibrosed valves, with the timing ranging from several months to years after the onset of Kawasaki disease. Some of these lesions require valve replacement. Causes. The specific cause of Kawasaki disease is unknown. One possible explanation is that it may be due to an infection triggering an autoimmune response in children who are genetically predisposed. Other explanations exist. The pathogenesis is complex and incompletely understood. Some circumstantial evidence points to an infectious cause. Despite intense search, no specific pathogen has been identified. Debate has occurred as to whether a conventional antigenic substance or a superantigen may be implicated. Data have revealed a correlation between Kawasaki disease and tropospheric wind patterns. Winds blowing from Central Asia correlate with Kawasaki disease cases in Japan, Hawaii, and San Diego. This association with tropospheric winds has been shown to be modulated at seasonal and interannual timescales by the El Niño Southern Oscillation phenomenon, suggesting possible involvement of a wind-borne pathogen. Efforts have been made to identify a possible pathogen in air filters flown at altitude above Japan. Diagnosis. Kawasaki disease can be diagnosed only clinically. No specific laboratory test exists for this condition. Establishing the diagnosis is difficult, especially early in the course of the illness, and frequently children are not diagnosed until they have seen several healthcare providers. Many other serious illnesses can cause similar symptoms, and must be considered in the differential diagnosis, including scarlet fever, toxic shock syndrome, juvenile idiopathic arthritis, and childhood mercury poisoning. Classically, 5 days of fever plus 4 of 5 diagnostic criteria must be met to establish the diagnosis. The criteria are: erythema of the lips or oral cavity or cracking of the lips, rash on the trunk, swelling or erythema of the hands or feet, red eyes, swollen lymph node in the neck of at least 15 mm. Many children, especially infants, eventually diagnosed with Kawasaki disease, do not exhibit all of the above criteria. In fact, many experts now recommend treating for Kawasaki disease even if only 3 days of fever have passed and at least 3 diagnostic criteria are present, especially if other tests reveal abnormalities consistent with Kawasaki disease. In addition, the diagnosis can be made purely by the detection of coronary artery aneurysms in the proper clinical setting. Investigations. A physical examination will demonstrate many of the features listed above. Blood tests. Complete blood count may reveal normocytic anemia and eventually thrombocytosis. Erythrocyte sedimentation rate will be elevated. C-reactive protein will be elevated. Liver function tests may show evidence of hepatic inflammation and low serum albumin levels. Other optional tests include: electrocardiogram may show evidence of ventricular dysfunction or, occasionally, arrhythmia due to myocarditis. Echocardiogram may show subtle coronary artery changes or, later, true aneurysms. Ultrasound or computerized tomography may show high drops of the gallbladder. Urinalysis may show white blood cells and protein in the urine without evidence of bacterial growth. Lumbar puncture may show evidence of aseptic meningitis. Angiography was historically used to detect coronary artery aneurysms, and remains the gold standard for their detection, but is rarely used today unless coronary artery aneurysms have already been detected by echocardiography. Treatment. Children with Kawasaki disease should be hospitalized and cared for by a physician who has experience with this disease. When in an academic medical center, care is often shared between pediatric cardiology, pediatric rheumatology, and pediatric infectious disease specialists. To prevent damage to the coronary arteries, treatment should be started as soon as the diagnosis is made. Intravenous immunoglobulin is the standard treatment for Kawasaki disease and is administered in high doses with marked improvement usually noted within 24 hours. If the fever does not respond, an additional dose may have to be considered. In rare cases, a third dose may be given to the child. IVIG by itself is most useful within the first 7 days of onset of fever, in terms of preventing coronary artery aneurysm. IVIG given within the first 10 days of the disease reduces the risk of damage to the coronary arteries in children, without serious adverse effects. Salicylate therapy, particularly aspirin, remains an important part of the treatment, but salicylates alone are not as effective as IVIG. There is limited evidence to indicate whether children should continue to receive salicylate as part of their treatment. Aspirin therapy is started at high doses until the fever subsides, and then is continued at a low dose when the patient returns home, usually for 2 months to prevent blood clots from forming. Except for Kawasaki disease and a few other indications, aspirin is otherwise normally not recommended for children due to its association with Reye syndrome. Because children with Kawasaki disease will be taking aspirin for up to several months, vaccination against varicella and influenza is required, as these infections are most likely to cause Reye syndrome. High-dose aspirin is associated with anemia and does not confer benefit to disease outcomes. About 15 to 20% of children following the initial IVIG infusion show persistent or recurrent fever and are classified as IVIG resistant. While the use of TNF-alpha blockers may reduce treatment resistance and the infusion reaction after treatment initiation, further research is needed. Prognosis. With early treatment, rapid recovery from the acute symptoms can be expected, and the risk of coronary artery aneurysms is greatly reduced. Untreated, the acute symptoms of Kawasaki disease are self-limited, but the risk of coronary artery involvement is much greater, even many years later. Many cases of myocardial infarction in young adults have now been attributed to Kawasaki disease that went undiagnosed during childhood. Overall, about 2% of patients die from complications of coronary vasculitis. A relapse of symptoms may occur soon after initial treatment with IVIG. This usually requires rehospitalization and retreatment. Treatment with IVIG can cause allergic and non-allergic acute reactions, aseptic meningitis, fluid overload, and rarely, other serious reactions. Overall, life-threatening complications resulting from therapy for Kawasaki disease are exceedingly rare, especially compared with the risk of non-treatment. Evidence indicates Kawasaki disease produces altered lipid metabolism that persists beyond the clinical resolution of the disease. Rarely, recurrence can occur in Kawasaki disease with or without treatment. Epidemiology. Kawasaki disease affects boys more than girls, with people of Asian ethnicity, particularly Japanese and Korean people, most susceptible, as well as people of Afro-Caribbean ethnicity. The higher incidence in Asian populations is thought to be linked to genetic susceptibility. Incidence rates vary between countries. Currently, Kawasaki disease is the most commonly diagnosed pediatric vasculitis in the world. By far, the highest incidence of Kawasaki disease occurs in Japan, with the most recent study placing the attack rate at 218.6 per 100,000 children less than 5 years of age. At this present attack rate, more than 1 in 150 children in Japan will develop Kawasaki disease during their lifetimes. However, its incidence in the United States is increasing. Kawasaki disease is predominantly a disease of young children, with 80% of patients younger than 5 years of age. About 2,000 to 4,000 cases are identified in the U.S. each year. In the continental United States, Kawasaki disease is more common during the winter and early spring. Boys with the disease outnumber girls by 1.5 to 1.7 to 1, and 76% of affected children are less than years of age. History. The disease was first reported by Tomosaku Kawasaki in a 4-year-old child with a rash and fever at the Red Cross Hospital in Tokyo in January 1961, and he later published a report on 50 similar cases. Later, Kawasaki and colleagues were persuaded of definite cardiac involvement when they studied and reported 23 cases, of which 11 patients had abnormalities detected by an electrocardiogram. In 1974, the first description of this disorder was published in the English language literature. In 1976, Mellish et al. Described the same illness in 16 children in Hawaii. Mellish and Kawasaki had independently developed the same diagnostic criteria for the disorder, which are still used today to make the diagnosis of classic Kawasaki disease. A question was raised whether the disease only started during the period between 1960 and 1970, but later a preserved heart of a 7-year-old boy who died in 1870 was examined and showed 3 aneurysms of the coronary arteries with clots, as well as pathologic changes consistent with Kawasaki disease. Kawasaki disease is now recognized worldwide. Why cases began to emerge across all continents around the 1960s and 1970s is unclear. Possible explanations could include confusion with other diseases such as scarlet fever, and easier recognition stemming from modern healthcare factors such as the widespread use of antibiotics. In particular, old pathological descriptions from Western countries of infantile polyarteritis nodosa coincide with reports of fatal cases of Kawasaki disease. In the United States and other developed nations, Kawasaki disease appears to have replaced acute rheumatic fever as the most common cause of acquired heart disease in children. Since April 2020, a slight increase in childhood illnesses, newly named pediatric multisystem inflammatory syndrome, similar to Kawasaki disease, has been observed in the USA and some European countries. The WHO is examining a possible link with SARS-CoV-2 infections. Kawasaki disease